chairpersons and seniors and my dear friends. I've been given 7 minutes to discuss about the non-steroidal amyloid receptor antagonist, Finerenone. So we will discuss the topic under the following questions. What are the benefits of MR receptor antagonism? And does the steroidal MRI, is it worth all the hype? Does the steroidal MRI have all these benefits? And then why do we need the non-steroidal MRI? And what are the trials, what are the guidelines, and dosing and how to use? So among many other organ systems, the aldosterone causes renal inflammation, fibrosis, and glomerulosclerosis and proteinuria. In the heart, it causes hypertrophy, remodeling, fibrosis, and inflammation. So MRI blocks this, results in improved coronary perfusion, decreases the arterial stiffness, and at the renal level, it reduces the albuminuria and promotes the renal function. So it has blocking the MR receptor has renal and cardiac benefits. Why this is important? Patients at an early stage of CKD, even at a low GFR of more than 60, and a mild albuminuria at a high risk of cardiac vascular disease, that is 1.7 times the risk of CV disease than other patients without CKD. So in the light of this, the guidelines recommend yearly GFR testing and albuminuria testing in patient ACR, urine ACR in all diabetic patients. So a brief about the evolution of mRNA. As you already know, there are spironolactone and eplerenone are already established in heart failure with reduced ejection fraction. Also, it was tried in albuminuria. Multiple systemic analysis showed there was a reduction of albuminuria, but the problem was side effects, that is hyperkalemia and anti-androgenic side effects. So that's where the non-steroidal MRA comes in the picture. So again, all the meta-analysis showed there is a benefit, but the side effects were more. So how does the non-steroidal MRA differ? First, it has an equal distribution. The steroidal MRA is more concentrated in the kidneys compared to the Finerenone, which has an equal distribution in renal and cardiac system. And selectivity is more selective, and it has a more anti-inflammatory and anti-fibrotic effects. And there is a reduction in the progression of renal damage with Finerenone. It also has less or nil anti-androgenic effects, and the reduced risk of hyperkalemia in patients with CKD makes it an ideal choice in patients with CKD. So what are the clinical trials? These were the first two trials, phase 2 trials with a small number of N was small, and chronic heart failure and mild to moderate CKD. It was as effective as spironolactone, 25 or 50 mg per day, with a lower incidence of hyperkalemia and worsening renal failure. Then the ARTS-HF trial combined it with the spironolactone, eplerenone, and it showed as effective as eplerenone. Then came the major trials. Fidelio DKD in these patients with diabetes and CKD were who were already on AC inhibitors or ARB was treated with Finerenone, and the patients were having mild to moderate CKD and moderate to severe albuminuria. So you can see all these in this primary and composite outcome. There was a reduction in the kidney failure, which was end-stage kidney disease, sustained decrease in the eGFR, and also there was a key, the secondary outcomes, that is death from cardiovascular causes. All the boxes shows Finerenone is better, and there was a reduced hospitalization for heart failure. All these patients had a less incidence of hyperkalemia, and the discontinuation rate was very low, that is 2.3%. And there was no dietary restriction of potassium in these patients who are on these drugs. Then the other trial was Figaro DKD. In this, again, patients with diabetes and CKD who were already on RAS inhibitors were given Finerenone versus placebo. This was stage 1 to 4 CKD and moderate to severe albuminuria. These patients also showed benefit, that is primary cardiac death from cardiovascular causes, non-fatal MI, and hospitalization for heart failure was reduced in patients on Finerenone. And also patients with kidney disease, there was reduced progression of albuminuria and reduced progression to kidney failure. So this fidelity analysis showed that it was an analysis of both these trials, and there was reduced risk of clinically important cardiovascular and kidney outcomes versus placebo across the spectrum of CKD, that is stage 1 to 4 CKD in patients with diabetes mellitus. And there was the other advantage was the less number of hyperkalemia, that is only 1.7% needed discontinuation of Finerenone. Now another trial which was was Finerenone heart failure. There was a lower rate of composite worsening of heart failure events and death from cardiovascular causes than placebo in Finerenone. So it may be it will come in guideline maybe that Finerenone reduces heart failure hospitalization in heart failure with mildly reduced ejection fraction or preserved ejection fraction. Then the new trial that came last week was Finerenone with empagliflozin, which showed that Finerenone plus EMPA reduced albuminuria more than either of these alone. So there are a multitude of trials undergoing in ranges of reduced ejection fraction, preserved ejection fraction, and mildly reduced ejection fraction. It will come into the guidelines hopefully. And coming to the guidelines, what are the recommendations? Class 1 recommendation by European Society of Hypertension in patients with CKD and albuminuria. And again, 2023 guidelines for the management of cardiovascular disease in patients with diabetes, class 1 indication. Finerenone has given a class 1 indication. Now the KDIGO has given a class 2 indication for patients with a EGFR more than 25 and who is already on RAS inhibitors, class 2 indication for Finerenone. So how to use the Finerenone? We have to, if the EGFR is less than 25, it is not recommended. 25 to 60, you start at a dose of 10 milligram once daily. And if it is more than 60, you can start at a 20 milligram once daily. The target dose is 20 milligram once daily. And do not initiate if potassium is more than 5. Then up titration, the target dose as already said is 20 milligram. If it is less than 4.8, you have to increase to 20. Then if it is more than between 4.8 and 5.5, maintain 10 mg. And if more than 5.5, we can withhold. If you start on 20 mg, only if potassium goes above 5.5, you need to withhold. The take-home points: yearly monitoring of EGFR and albuminuria is indicated in all diabetic patients, and Finerenone can be started in all diabetic patients with CKD with at least a GFR of 25, and it reduces the heart failure hospitalization and progression of albuminuria, EGFR decline, and maybe might be a holy grail for treatment of mid-range ejection fraction and preserved ejection fraction. Upcoming trials may give further info about additional benefits on combination with SGLT2 inhibitors. Thank you.